Osteosarcoma is a malignant bone forming or osteoid matrix forming tumor of the bone. This is the most common primary non-hematolymphoid malignancy of the bone. Osteosarcoma has an interesting age distribution. It is bimodal, which means there is an initial peak around the adolescent age group, then there is a late peak after the 60s. 75% of osteosarcomas arise around adolescence, which aligns with the pubertal growth spurt of the bone. Then around 25% comes after the age of 60. Most of these are secondary osteosarcomas due to, say, chronic inflammation of the bone, as in osteomyelitis, or some disease of the bone like Page's disease. And so, this group, this adolescent group, where osteosarcomas occur without any previous disease, these are called primary osteosarcomas. With that in mind, let's look at the pathogenesis. Osteosarcomas occur usually at the metaphysis of long bones. Why? Because this is the area where maximum bone growth happens. A long bone basically has three parts: epiphysis, metaphysis, and diaphysis. When somebody goes through adolescence, because of the hormonal influence, rapid cell division occurs at the growth plate. Osteosarcomas occur at the growth plate of rapidly growing bones. During adolescence, there is a pubertal growth spurt because of various hormones. This leads to increased proliferation of cells, which increases the chances of mutations. This is the basic pathology behind osteosarcoma. Here, you may see very complex karyotypes and numerous chromosomal aberrations. The most common mutations in osteosarcoma occur in famous tumor suppressor genes. Retinoblastoma gene, which basically acts at the G1S checkpoint, inhibits MDM2, which inhibits p53, the guardian of genome. So indirectly, RB promotes p53. Mutations can occur to all of these three genes in osteosarcoma. Along with this, other cyclin dependent kinase like CDKN2, which produces p16 and p14, which promotes retinoblastoma, and p14 inhibits MDM2. So mutations can occur to any of these things in osteosarcoma. Now let's look at the morphology. In an X-ray, osteosarcomas appear as an osteosclerotic and lytic destructive lesion around the metaphysis of bones. The tumor can reach up to the periosteum, and once it reaches the periosteum, it lifts the periosteum. So this lifted periosteum looks like a triangle. This is called Codman's triangle, and this can lead to periosteal new bone formation, which sort of looks like rays of the sun. This is called sunburst appearance. And grossly, we can see a gray-white tumor, which is gritty when you cut it, with areas of hemorrhage and cystic degeneration. The tumor can spread to the surrounding soft tissues or into the medullary canal. This brings us to the microscopy of osteosarcoma. Under the microscope, you can see cells with large nucleus with minimal cytoplasm, and these nuclei are of different shapes and sizes. So you can see pleomorphic large nucleus which are hyperchromatic, means they are very blue in color. Usually you can see atypical mitosis. which basically means instead of a usual mitosis where chromosomes divide into two, you may see multipolar arrangement like this, like a star bursting. Along with these, you may see tumor giant cells, which are bizarre and large and multinucleated. Along with all of these, we require one more thing for diagnosis of osteosarcoma, which is that we have to see tumor cells directly producing osteoid or bone. Means you can see this pink material which these cells are directly producing. This is osteoid, or it may also be mineralized bone. So, for the diagnosis of osteosarcoma under the microscope, you have to see osteoid production by tumor cells which have pleomorphic large nucleus, hyperchromatic nucleus, and lots of mitosis with atypical mitosis and bizarre tumor giant cells. Clinically, osteosarcomas most commonly occur at the metaphysis of long bones, 50% of which are around the knee joint. It is assumed that almost all osteosarcomas would have metastasized by the time it is diagnosed, or they present with occult metastasis, because of which treatment of osteosarcoma is done by chemotherapy first, followed by surgery, followed by chemotherapy. Currently, the 5-year survival rate of patients with osteosarcoma who have received chemotherapy is around 70%. But for those patients who present with very clear metastasis, the survival rate is quite low. It's only up to 20%. In the next class, we'll look at osteoclastoma or giant cell tumor.